Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I'm your co-host, Dr. Karen Bodnar. I am a pediatric hospitalist at Inova Children's Hospital and an assistant professor of pediatrics at Virginia Commonwealth University.
I'm also a board-certified lactation consultant.
This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education and is co-sponsored by the Academy of Breastfeeding Medicine. Hi, Karen. How are you?
Oh, I'm great. How are you?
Good, really good. So we're going to talk about a couple things. We have three studies that we're going to talk about. The first one I'm going to mention is called Osteopontin in Human Milk and Infant Formula Affects Infant Plasma Osteopontin Concentrations. So this was published in January 2019 in a journal called Pediatric Research, and the researchers were Rulan Jiang and Bo Lahnerdal. And Bo Lahnerdal we've heard from many times. He's a bench researcher. His name is pretty popular. Have you ever heard of this protein, osteopontin?
Osteo who?
Right. That's why it took me a couple of times to just practice saying it. But the amazing thing is that it's very abundant in breast milk, and it's not in formula. It's actually a protein that has a lot of immunologic functions, such as being immunomodulatory, which for people who don't know that term, it means it kind of like dampens down the immune system when the immune system is getting too excited, such as super high fevers. It is involved in tissue remodeling, bone formation, and then it has a lot of other cellular functions, like it affects cellular attachment, migration, proliferation, which is the growth of adding more cells, and differentiation, which is maturity of the cells. But interestingly, it's made by many of our tissues, like heart and liver and lung, and it's in all body fluid. So if you were to look at lung fluid or urine or something like that, you'd see it. And it's really high in breast milk, and in fact, it's one of the 5 most abundant proteins in breast milk, which is so interesting. Why we haven't talked about it before? Yeah. It's been found to be resistant to neonatal gastric acids, which means that it's not broken down in the stomach. Because sometimes you wonder, if it's in breast milk and it goes into the infant, does the infant absorb it? And so then one way to figure that out is to find out if it's broken down in the stomach, and it isn't. And studies have shown that when infants ingest it, the osteopontin levels increase in plasma. And we'll talk a little bit more about what that means in a moment. So there was a clinical trial that showed that adding a bovine or cow form of the osteopontin to formula showed that infants had a change in their inflammatory cytokine levels, and they also had an immune cell profile that was more similar to breastfed infants than to infants who were receiving formula. So it seemed to have an effect on the immune system. And they also found that these infants had that their fevers were not as high as compared to infants who were fed regular formula. So this study, these authors in this current paper, is a study that looked at the osteopontin levels in breast milk over the time of lactation. So they did 2 things. The first thing they did is they looked at the level of the osteopontin in breast milk over time. So they took 12 women who were from Davis, California, and on days 1 through 14 postpartum, as well as months 1, 2, 4, 6, and 12, they had the mothers express all the milk from one breast once and looked at the osteopontin levels. And then they did another study where they took plasma levels of osteopontin. They measured plasma levels of osteopontin in Chinese infants. And they compared the Chinese infants in different groups. So each group had 25 infants. And one group, the infants were fed regular formula without any osteopontin. One group was exclusively breastfed. One group was given formula that had 65 milligrams per liter of osteopontin, and one group had formula with twice as much, with 130 milligrams per liter of osteopontin. And the osteopontin that was added to the formula was a bovine form. And then in the infants, they measured their levels at 1 month, 4 months, and 6 months to see what their osteopontin levels were. So in the breast milk, they found that the osteopontin levels were the highest. When do you think? Higher in colostrum or higher in mature milk?
I mean, I'm guessing, but I'll say colostrum.
Right, exactly. Just like other proteins.
Yeah.
Right. So it was, in colostrum, it was about 178 milligram per liter. And then it kind of went down rather rapidly. Between 8 and 14 days, it went down to 130 milligram per liter. And then by the time 12 months came around, it was about 50 milligrams per liter. Then they looked at the plasma level in those Chinese babies, and they found that the osteopontin level was highest in the babies who were breastfed at the first month. And then the osteopontin level was lower in breastfed babies at 4 months and 6 months. And the babies who were given formula without the osteopontin level, you would expect they had the lowest levels, but they did have osteopontin, and it was a significant amount. So we know that these babies were able to make it. And then the babies who got the formula, like the 65 milligram and the 130 milligram, their levels were really pretty similar at 1 month, 4 months, and 6 months, and actually pretty similar to the levels that the breastfed babies had. So that was interesting. Then they wanted to know, well, gee, that we know that infants can make osteopontin themselves because the formula group, obviously made their own. They were the ones without the supplementation. Mm-hmm. So then they looked at the osteopontin in the babies who got the osteopontin through the formula, and they wanted to know, well, is that the bovine form or is that the human form? And they found out that it was actually the human form. So they weren't really absorbing it from the formula, but with having it in the formula, it stimulated their system to actually endogenously make it themselves. So that was really interesting.
You know what this makes me think, as I've thought several times about studies out of Davis. Oh, maybe that part wasn't out of Davis. Is that they have too many mass spectrometers and they don't know what to do with them.
Right. It's kind of an amazing problem to have. I thought that was really interesting, though. I didn't, they don't kind of go into more details to why they hypothesized that, why they even investigated that, but that is interesting.
This whole thing just blows me away. Like, who are these people in China who are like, maybe their osteopontin labs are way, way more advanced than ours, but like this protein that I've never heard of, let's make formula with it. And what ethical agency said, sure, give that to these 25 babies?
Well, I think what happens is that a lot of the stuff that goes on with molecules, chemicals, substances, enzymes, or whatever in breast milk, a lot of it's animal studies, right? Like when I look at PubMed, once a week or every couple of weeks, half the studies on breast milk have to do with their pups, their bovine, their goats, their sheep, their whatever kind of animal.
Yeah.
And half are 2/3, or I'm sorry, like 1/3 are human. And so there's all this stuff that's going on that we don't even know about yet, like what's going to come up next, like coming from that bench research and then coming up to us where they start to look at like the clinical effectiveness or application of this stuff that they're learning about at the bench level. And I think this is one of these things that we're seeing bubbling up from research is the osteopontin. And so
this is translational research right here.
It's translational research. And so what's interesting about that is that there have been animal studies, and I want to talk about one of those. So one thing that they say is that the levels of osteopontin are higher in colostrum and lower as the milk ages, as the mother, later postpartum. Not as the milk ages, but as the mother ages over time. And they hypothesized that the higher levels early on probably have a different role than the lower levels that are in breast milk later on. And so this has been looked at with lactoferrin, which we know a lot more about, and that's the most abundant protein in breast milk. And they know that the higher levels that are in the colostrum play a role in proliferating the intestinal wall early on, but then the lower concentrations later actually promote cell differentiation, so more of the maturity of the cells. So it's still unclear what the higher levels do versus the lower levels later on for the osteopontin. But there is animal research showing that osteopontin not only plays a role in the immune system, but it also plays a role in gut maturity and brain maturity. And it has been shown to enhance myelination of brain cells in mouse pups. And so then there was one study that was done, and this is what I mean by like bubbling up from like, bench and, lab rat research, is that they took what are called wild type mice, mice that don't have like genetically screwed up kind of things. They're wild type mice who are breastfed by their wild type mothers. And they looked at their ability to remember and their learning ability, and they compared it to mice who were birthed and nursed by knockout osteopontin mothers. So these are mothers that don't have the ability to generate their own osteopontin, so it's not in their breast milk, it's not in their body fluid. And those mouse pups who were nursed by those mothers did not have the same ability to learn and to remember. So so it's interesting. So can't wait to see. I should start looking at that bovine and mouse research more closely to see what's going to come up next.
God.
Yeah.
I am geeking out, loving it. That's so cool.
Yeah.
Okay. Well, back to some human research over here. I wanted to talk about this recently published study in breastfeeding medicine, which was titled Breastfeeding Difficulties, Breastfeeding Duration, Maternal Body Mass Index, and Breast Anatomy. Are they related? And that was by Lawrence Mangel, Francis Mimouni, Dror Mandel, and a couple of others. And in this article, the authors examined the influence of maternal body mass index, or BMI, and of breast and nipple anatomic variations on breastfeeding difficulties and duration. This was a prospective observational study. In it, data was collected from 109 mothers of full-term newborns, and the women were classified as underweight, normal weight, overweight, and obese using World Health Organization definitions, and were otherwise healthy. Specifically, they excluded moms who had diabetes. Then breast anthropometrics were assessed and recorded after delivery and during hospitalization. The 4 pre-pregnancy BMI groups included 12 underweight, 59 normal weight, 20 overweight, and 18 obese women. The higher the BMI group, the larger the breast was, and that was significant. And in univariate regression, nipple diameter, nipple length, and areola diameter correlated significantly with breast size. The overall rate of latching difficulties was 15.5%, without significant differences among all 4 BMI groups, with the same percent protruding versus flat in the different groups. Early latching difficulties predicted shorter breastfeeding duration, and the authors conclude that high pre-pregnancy BMI has a negative impact on breastfeeding initiation and duration. And high pre-pregnancy BMI was also associated with decreased breastfeeding at 6 months. So I thought this was interesting for a few different reasons, some of which have to do with the questions they asked. And, there's been a lot previously that has shown that there's an association with shorter, and I should say less initiation and shorter duration of breastfeeding in mothers with high BMI.
Yeah, for a lot of different reasons.
Yeah, there are a lot of theories as to why that is the case. Is it, a higher rate of C-section? Is it diabetes causing delayed lactogenesis too? Is it, lots of different things.
Yeah, absolutely.
In this study, the obese women had a shorter duration of breastfeeding, and the other association that was found was that increasing birth order had a longer duration. So the primates had shorter duration than moms who had more children. The other thing, and that wasn't a surprise to me.
Yeah, that's like, I would bet money on that, and I don't typically gamble, so. Yeah.
The other thing that was interesting in here was that the obese women had less weight gain, which that is, I think, not a surprise to people who work in this area.
Right. Right.
And I wonder, this really made me think about the conversation we had last time we were podcasting, which was about trying to assess the glandular tissue and mom's potential for making milk and breast growth during pregnancy, and how if moms aren't gaining as much weight during pregnancy, that might change our perception of their breast growth during pregnancy.
Mm-hmm.
Because with this study showing that larger women have larger breasts, and we know that that difference is really fat that's in the breast.
Mm-hmm.
It's not that they have more glandular tissue. It makes it harder to assess changes during pregnancy, I would imagine.
Yeah, it's really hard to assess. That you can't tell the difference between fat changes and glandular changes. That's why that whole thing of like,
not
well,
externally.
Yeah, no. And then you don't know, is it larger, just a larger thorax with a larger, going from like a 38, C to a 38D, or is it cup size?
Well, that was the other thing, was how they measured the breast. It was based on this breast, like, broad database. And I'm like, thinking about all the different ways that we measure things in medicine. They submerge people to understand, not normally, but sometimes in research study, to understand their lung volumes and do all sorts of things. And if you look at the statistics on whatever very large percentage of women are wearing the wrong bra size.
Yeah. Victoria's Secret will tell you that they always change women's bra sizes.
That's right. And so, like, when you read the study, it says, like, within diameter and areola size were measured, using taping, basically, a measuring tape. And then they use this bra sizing to measure the breast. And I'm like, how do I know it was the right bra size?
Right. Yeah.
Seems
plus,
suspect to me.
Yeah, plus bras are, sports bras. A lot of women wear sports bras, and so, or bralettes, so you buy the one size, and then, how do you, women often.
I feel like you need to do some sort of breast submersion to, like, get the volume of the breast. I don't know.
Yeah, there needs, or you can just use, good old engineering principles of, like, calculus of trying to figure out the size of a mound, the area under the curve, kind of thing.
Yeah, absolutely.
Yeah.
And then the other thing was they made a point to say that the overall rate of latching difficulties was similar in the groups of 15%. However, 58% of women did not answer the question on latching difficulties.
Oh, that's not very good.
I'm like, how does the abstract say all the groups were similar, and then, like, 2/3 of the people didn't answer that question? And then they went on to say there were, I don't know, like around 14 participants were lost to follow-up. In the 95 mothers with complete follow-up until 6 months, of those who said they had latching difficulties, 71% of mothers who did not report latching difficulties were still exclusively breastfeeding at 6 months, while only 28% of those who had initial latching difficulties were still exclusively breastfeeding at 6 months.
Mm-hmm.
That is a huge difference. But the latching difficulties were self-reported on this questionnaire, and it wasn't specific to the baby didn't open, it was pain. I just feel like we're not doing a good job of quantifying that.
No, but the other thing I would say is that in my lactation clinic, when women call for a consultation, like I just saw a woman yesterday who called to make an appointment. She's pregnant. Her first baby, she said, my first baby just didn't latch well, and I wanted that to be better this time. And so she came in. She's due, in a few weeks, and we talked about, like, all the details. And the reason why her baby didn't latch well is because she has insufficient glandular tissue, most likely. So the baby stopped nursing. So the underlying reason was because she didn't have enough milk, and when she pumped for 2 months, she never could come close to the amount of volume that the baby took, even though her breast felt full when she pumped. So she called that latch difficulty because there was no explanation to her. So what does latch difficulty mean?
That's exactly my point, right. Is that, sometimes I see people like, in the hospital, and they're like, oh yeah, it's going great. The baby's eating for an hour every hour. That doesn't
Yes.
seem great to me.
No,
And
exactly.
sometimes
Right.
they're like, oh yeah, they latched great. It was 3 times in 24 hours that the baby
Right.
was fed at the breast. And I'm like,
Right.
also not great. So I've been giving a lot of thought to this idea of how to give a score like we do for, bilirubin to people who are leaving the hospital as to what their risk is for
Yeah.
breastfeeding success. And I haven't come up with all of my criteria yet, but somehow
Yeah.
this has got to play into it. And in the past, I've only read studies about actually like latch scoring system.
Right. Right.
And it's not all the latch, it's so many other things.
Right. It's so many other things. And I think that, those prenatal risk factors that we're aware of and intrapartum risk factors, hemorrhage and, baby is 35 to 37 weeks. I mean, there's so many different things that, rather than just that actual latch. So no, we definitely need a lot. I mean, it's only fair that we just have a really good scoring system. Like we have great scoring systems for CURB 65 for pneumonia, and we have, or for lung disease, for death, for lung disease, or we have, the CHADS VASC2 score, that's on like its third or fourth iteration.
Yeah. And there's
for
really
atrial
great
fibrillation.
postpartum depression and anxiety,
Right.
scoring sheets that I have in clinic.
Right. Yeah. I mean, there's lots of, we use the GAD-7 for anxiety. We use, PHQ-9 for depression. I mean, there's all the kinds of scoring things that we do. There's one for erectile dysfunction and for, urinary problems for men with prostate cancer, all kinds of stuff.
This is so educational. I don't know about any of those things.
Yeah, they come live with me or come to my office.
All the old people problems.
Yeah, that's what happens when these babies grow up. Yeah, I mean, we have all kinds of scoring, so we desperately need scoring. And I think the scoring not only is, it's going to be more comprehensive than just looking at one particular factor. We need to look at all the factors, but we need this in order to make sure to keep moms and babies safe postpartum. So scoring for risk of mastitis, scoring for risk of insufficient infant weight gain, scoring for risk of hyperbilirubinemia, I think are really important. So. Yeah, and I think the scores can work really well. We look at scoring, I use FRAX scoring all the time for women who are being evaluated for osteoporosis with their bone densities. And that plays a really important role in what we do, in terms of treating women, to prevent fractures. So, yeah, I feel like, we have all this bench research and we have a lot of epidemiologic research, but we don't have kind of the rubber to the road, like studies that really influence practice, that are going to, make babies safer and moms safer.
Yeah, I mean, it's those babies that go out and get severely dehydrated that we want to avoid the most. But then the secondary to that is the babies that get unnecessarily supplemented and just continue down that path. And I think that the hardest thing about this to me is that it's such a moving target. And so, I can give you a score for the next 24 hours, and that's going to impact the first week, and that's going to impact if you make it to 6 months in a year. But I can't tell you, based on today, what's going to be happening in 2 weeks for a newborn. There's just too many factors that so many of them have to do with what support you get if you do fall into trouble.
Right.
And that's so I think the goal is trying to identify the people who need to be watched more closely.
Right. Like the score of who needs to be seen on day 72 hours, and then another score for okay, you can wait, for 96 hours or whatever.
Well, you can just go to your pediatrician and they can probably handle it. And if not, they should let us know. And you definitely are going to need more help than that.
Right. Exactly. Yeah. Or their family doctor.
Yes, I knew.
You knew I was going to say that.
Busted.
All right. So the third thing that we're going to talk about today is that article that came out. Many people who are listening probably heard about this. The Center for Disease Control and Prevention report on the receipt of breast milk by gestational age from 2017. So this was published in the MMWR, which is the Center for Disease Control's a weekly report called Morbidity and Mortality Weekly Report from June 7th, 2019. And this report states that 10% of infants are born prematurely, and the Center for Disease Control acknowledges that breast milk is important to prevent sepsis, necrotizing enterocolitis, and to promote neurologic development, particularly for premature infants. So what they did is they analyzed birth certificate data from 2017, and this data came from 48 states. There are 2 states it didn't come from. One is, I think, Michigan, and one from California, and then also from DC. And on these birth certificates, it states whether or not they received breast milk. So it doesn't talk about like how long they received breast milk, because obviously it's a birth certificate, and birth certificates are done really quickly after the baby's born, and they're submitted really pretty quickly. So what they found in this birth certificate data is that 83.7% of all infants in 2017 received any breast milk, which is actually quite good. Mm-hmm. And then they broke it down into prematurity status. And so 71.3 of the extremely preterm infants who were born at 20 to 27 weeks received breast milk. And 76% of early preterm received breast milk, and that's 28 to 33 weeks. And then the late preterms from 34 to 36 weeks, 77.3 received breast milk. So there was a slight increase over time. And then for the babies who were term over 37 weeks, it was 84.6% received breast milk at some point. So then when they broke it down by racial status, they said that among the 20 to 27 week preemies, 67.1% of the infants born to African American women received breast milk, and then only 60.7% of infants born to Native Americans or Native Alaskans received breast milk, and then as compared to 75% of infants between 20 and 27 weeks who were born to mothers of all other racial groups. So that's a huge difference in the amount of breast milk received. And then this difference was seen across all age groups between the different races. And then, of course, as per our other demographics, they found that infants of mothers who were younger, less educated, unmarried, and those who participated in Medicaid or WIC were less likely to receive breast milk. So in the discussion, they do mention that maybe one of the reasons why the 20 to 27 weekers overall receive less breast milk is because when they're first born, sometimes they don't receive anything enteral. They just have IV treatment because of oral motor immaturity. Although, there is that evidence, of course, swabbing the mouth, and that using the swabs and the oral care has been found to be really important in seeding the gut. So hopefully that will take off because there's good evidence for that. And then they also mentioned that maybe mothers of preemies may not be able to make as much breast milk, but I don't think of that as a good reason because, they overall are still going to have colostrum and, small volumes, especially for those really early preemies. So
sure. There are 2 other factors that come to mind. One is that, depending, I don't know, particularly if we're thinking about, places where there are more rural, if I think about Native Americans, I think a lot of those people are in rural areas.
Yeah.
And perhaps there's more likelihood that they are, the babies end up being transferred if they're really early preemies to a tertiary care center, so they're separated from the moms. And there is data that has come out that shows there's a disparity in terms of donor milk provision in hospitals that have higher rates of minorities versus hospitals that have more Caucasians. And so, if your baby is transferred and it's in an area that doesn't have as many resources, there may be less of a chance that they will get donor milk if you're not with them. Right.
And they actually mentioned in there that in this article that the infants who were transferred, that they didn't have, there were some infants where they didn't have that data. because the infants were transferred. So, but then that segues, what you said segues into my next comment, which is that they mentioned that their MPINC data, which is the scoring that the maternity practice and neonatal care, infant nutritional care, I think it is, MPINC, the scores where the hospitals, basically, talk about, like, they score themselves in terms of, how baby friendly they are. In 2015, 66% of level 3 NICUs and 73% of level 4 NICUs use donor milk. So the level 3 NICUs are usually more rural. I mean, there's some level 3s in cities, but, when I look at what's happening rurally in Wisconsin, the level 3s are out there in the rural areas, and the level 4s are in, just Madison and Milwaukee for the most part, maybe a couple other cities. But
that's interesting because we have so many hospitals. I'm in the DC metro area, and we have so many hospitals, but only a few have level 4.
Yeah, I mean, you don't need that many level 4.
You don't need that many.
Yeah, but I would think still, I think level 3s are more likely to be in rural areas. So, they basically say that, look, it's really important that hospitals and healthcare providers implement policies and practices to ensure that all dyads receive support for breast milk feeding. And this includes the need for that really consistent prenatal education throughout the prenatal period, because obviously women deliver early and they need to have this information, not just when they start their childbirth classes at 30 weeks, but before that. And hospitals should increase access to donor milk since it's evidence-based, and the AAP also endorses the use of donor human milk when there's not enough mother's own milk. And then to provide long-term breastfeeding support for mothers, particularly for those who have to pump, but for all mothers, all mothers need to be supported over time. So that's basically it. So I was really glad to see that push. That's one more, piece of data that should be shared with hospitals who have not been incorporating the use of donor milk. And I would really like them to do another study or another report that tells them that they should also use it on the floor too, not just in the NICUs.
Yeah, I mean, there are some big national databases that NICUs use for quality improvement to sort of keep track of who's doing what. And lately I've been wishing that we had sort of a similar thing for postpartum units for level 1 nurseries that would make it easier for us to compare across the nation how many people are using donor milk with term infants, and what are the policies and procedures, and what's the variation across the country. I get emails constantly from different groups that I belong to that are talking about, we want to update our hypoglycemia policy, and are you guys using glucose gel, and what cutoff do you use for low sugar, and people trying to gather other examples so that they can form their policy, because the research into a lot of those things there's a lot of it, but it's not, the studies are really, often they conflict, and we don't have, a lot of it's based on expert opinion.
Yes, a lot of it is. And yeah, and also, I mean, you have all your committees at hospitals of different people who have different,
personalities.
Ethics or different values, and they put their values into, what really they should be putting the evidence before the values. But,
sometimes it's like anxiety. So
yes,
I think, sometimes people, I get frustrated because they're nervous, they're trying to choose like a really high cutoff for hypoglycemia, so they'll catch everybody, and not appreciating that they're doing harm by, doing more interventions on these babies that have low sugars that are 49. And I'm like, it's a normal sugar. Please stop supplementing with formula.
Yeah. Yeah, I know, it's really hard. And then, not really understanding the difference between whole blood and serum and venous and finger stick and all those other issues too. So there's a lot of different interpretations of blood sugar as well. So that's a tricky.
It's a super complicated issue.
It is really complicated. Yeah. Yeah. So anyway, so that's it for today. Do you have any other things you want to talk about today?
I could digress, but maybe I'll save it for the next time.
Yeah, we'll come up with some other really good topics next time.
Sounds good. Bye, Anne.
Bye. For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.